You've seen the Eurosets booth out there. You see some new equipment that we don't quite have our hands on quite yet, but it'll be coming up in the next, who knows, hopefully within the next year, because we sure need some of that stuff here in the US. So I'm going to introduce our first person who's not our speaker, but he's responsible for bringing our speakers in from Italy and from Wisconsin. His name is Carlo Alberto. He is the Clinical Global Therapy Development Manager. So if I can have Carlo come up, and then we'll get right into our speakers.
Good afternoon to everyone. My name is Carlo Alberto Tassi. I'm Italian, so first of all, I apologize for my American language, but I will try to do my best. So I want to thank AMSEC first for this opportunity, because it's the first time that we carry out a symposium here in US. Thanks again to our moderator, Williams, and to our speakers. As an Italian company, we are manufacturing everything in Italy. We are located in the northern part of Italy, where there is, for instance, the facility from Ferrari, Maserati, etc. And we are starting, let's say, to introduce, trying first to clear the FDA new medical device, a new solution into the US market. Our goal, of course, is introducing value in a new market as such American important market. First of all, our mission, as I already said, is introducing innovation into conventional solutions, so bringing value to the US market. And we want to help people to get back doing the things they like. We mainly will start with two product lines, the cardiopulmonary and the extracorporeal life support. In terms of cardiopulmonary, we will have available, hopefully beginning of next year, two brand new oxygenators, one for adult called Horizon and one for pediatric called Trilly. Both are a real solution, and we will see later with the clinical experience coming from Europe, are a real solution to optimize the gas micro-emboli reduction in adult and pediatric population. Another very interesting device that will help a lot in monitoring and better understanding how we carry out extracorporeal circulation and ECMO is our brand new landing monitor. And now I will show you a quick video.
There are contexts in which every single moment is important. And it's exactly here that technology comes into play to help and support us during clinical practices. Comes to an end, we get how much every single step has been essential for a flawless landing.
Okay. The next product line is extracorporeal life support, and we are introducing a couple of devices. The first one is ECMOLIFE, that is the most gentle, safe and versatile solution for ECMO and ECLS. It features a magnetic levitating centrifugal pump for adult, can be used even for transport, is already validated for a road ambulance transport. It has an integrated backup unit and the possibility to measure up to 3 pressure channels, negative pressure along the suction line, pre and post membrane, plus oxygen, venous saturation, hemoglobin, and venous temperature, and this everything comes pre-connected. We have a possibility to carry out automatically the priming phase, and finally is fully PC coated. The other system is our latest ECLS solution that is called Colibri. Right now is the lightest system in the market, and here you will see.
Posso aiutarla? Adesso le mando subito i soccorsi.
Everywhere there is a life to save.
So if you want to see in details our solution, our new devices, ECMOLIFE and Colibri, I would like just to invite you, are more than welcome to join at our stand, just to see the technology in detail. Thank you very much.
As a part-time actor, I'd love to audition for some of your commercials there. That's fantastic. The drone, man, that sold me right there. Our first speaker, without further ado, is Flavio Cavallari, in terrible accent, right? He's the cardio, so he's from Italy, but he now is the Cardiopulmonary Perfusion Manager at the Medical College of Wisconsin. His first talk, Impact of Oxygenator Design on Pressure Drop, Shear Stress, and Hemolysis. So please help us know more about this.
Hello everyone, thank you for being here today. I'm very happy to be here in the US. I moved from Italy like 6 years ago. I went back to school to the MSOE and I was able really to be part of this perfusion community. Before starting, I would like to share with you a couple, 3 fun facts about 2 celebrities and 1 NFL team. So the first celebrity is Santa Claus. As you may know, Santa Claus' original costume wasn't red, but it was blue. And there is a misconception behind the idea of Santa Claus that is wearing red clothes, right? The second fun fact is about Albert Einstein. Many people think that he failed math class when he was young. He has never failed a math class. And the third, and maybe most important fun fact, is that many people think that Kansas City Chiefs are the best NFL team. I'm not here to tell you what's the best team. You might think that I'm biased, but yeah. So when I was thinking about this presentation, I also was thinking, well, maybe there is kind of misconception behind how our engineers and designers, they try to figure out how to manage shear stress, pressure drop, and hemolysis, right? So let's start from the beginning. There are many differences between natural lungs and membrane lungs. But one of the most important differences that we try to overcome when we design new oxygenators is try to reduce the blood path width, or try to fix this issue. As you can see, in our oxygenator, this difference is 25 times bigger than in the natural lungs. And there are many ideal characteristics when they try to design oxygenators. Of course, we want to oxygenate blood, venous blood. We want to remove CO2. We want them to be safe. And we want to have a small priming volume. But last but not least, we want to minimize blood trauma. There are many studies on the internet where the blood trauma or mechanical hemolysis. They start studying mechanical hemolysis since 1960s when our surgeons start placing prosthetic valves. And this is the first study about the relationship, try to investigate a relationship between shear stress and red blood cell damage. After that, there are many studies. You can go on PubMed and just type in shear stress, pressure drop, or hemolysis. You can find so many studies. And I found this last review about hemolysis and the use of MCS device and try to find the relationship between these problems. I really found this fascinating. This is why I'm here and trying to tell you more about that. So mechanical hemolysis factors, there are mainly two of them. There are normal stresses that we all know, it's pressure. Pressure is a force that's perpendicular to surfaces. And we have tangential stresses. And the most common that I'm sure that all of you know are shear stress. Very common, I think that many of us measure pressure drop. The pressure drop is the pressure that's based on the difference between the inlet and outlet of the pressure of the oxygenator. And using the Ohm's law, we can calculate the resistance. It's a very important number, but it's not so important if we consider this number by itself. What we want to know, and this is why we mainly measure pressure drop during our ECMO run, is because we want to have a trend. No, we don't really care about the absolute value. And also, you can go on the internet, you can find many studies about the effects of pneumatic forces on erythrocytes. This was a study a couple of years ago that showed that if you're going to apply a specific pressure on the same erythrocytes for 5 or 7, 10 or 15 minutes, there isn't a lot of hemolysis. So pressure is not the main cause of hemolysis in our oxygenators. Let's talk about a little bit about shear stress. Shear stress can cause a deformation of erythrocytes, and it's caused by material slippage along a plane or planes. As you can see, that's a classic common picture that you can find on every perfusion textbook. And this is what happened mainly in our tubing system. But is this a realistic representation of what's going on in our oxygenators? Well, the answer is no, because in order to overcome these issues, so in order to try to fix this problem, to reduce the blood path width, engineers need to generate turbulent flow. So in order to improve oxygenation, our designers, like Eurosets, needs to really increase turbulent flow. And that's what's shocking when I discovered this when I went to school. So there's a kind of pretty, let's start this video. That's kind of representation of what's going on. You can see here we have, on the left side, we have like a stream flow. And when the erythrocyte goes around the oxygenator fiber, they start losing velocity and they start generating a turbulent flow on the back side of the fiber. And if you're asking yourself if this is a golf ball, the answer is yes, but that's the best representation that I was able to find. And it's pretty accurate. Okay, let's go next. And so what we saw was that we need to increase turbulent flow in order to increase oxygenation, but this is going to lead to a higher shear stress. Higher shear stress is going to lead to higher hemolysis, and also turbulent flow is going to lead to higher stasis. So how did the engineers try to solve these problems? How they try to reduce this shear stress and still having a very high performance oxygenator? Well, Eurosets, many years ago, with Dr. Gale, they really redesigned the blood inlet pathway. And you can go around, you can walk around, see different oxygenators, and you're going to notice that this one is the only one where the blood inlet pathway has a different angle. And they also they create a new diffusion bloodstream concept. They also, in order to increase oxygenation, they also reduce the membrane thicknesses, and they use different material biosurfaces. So just a quick recap. I mean, we know that there is a relationship between shear stress and pressure drop, and both are important. But also there are different scenarios where our engineers they can design oxygenators having a lower shear stress but with a slightly higher pressure drop. And it's also important to remember that shear stress or pressure drop are not the main causes of hemolysis, for example, in our MCS patient. There are many studies that they prove that negative pressures have higher impact on hemolysis instead positive pressures. So what we should expect for the future? Well, a better advanced computational fluid dynamics, so stop using golf balls to study oxygenator fibers. We can use AI for solution or quantum computers to have a better realistic scenarios, or we can also use different materials and keep researching and studies, like, for example, my colleague and next speaker, Ignazio Condello, he tried to investigate the relationship between GME and pressure drop on specific ECMO oxygenators. Well, thank you so much for your attention, and thank you again for having me here.
Thank you, Flavio. Our next speaker, Professor Ignazio Condello, MS, PhD, is a chief perfusionist in Bari, Italy. He specializes in AI application and perfusion, biomedical monitoring, device studies, and impact on patient outcome. He also has a research fellowship program at the Maastricht University. His title, Clinical Evaluation of Micro-Embolic Activity with Unexpected Predisposing Factors and Performance of Horizon AF Plus during CPB. Announce your name better than I did, please.
Thank you so much, everybody. It's a great pleasure for me to introduce this presentation about clinical evaluation of microembolic activity for an expected predisposing factor on Horizon AF Plus during cardiopulmonary bypass. There are a number of different types of emboli during the conduction of extracorporeal technology, such blood clots, cholesterol, fat globules, gas bubbles, and foreign body. Today we talk about the gas embolism. The deleterious effects of gas embolism are in relation to the ischemia and the hypoxia, such occur downstream of the occlusion of the gaseous microemboli. And the deleterious effects of ischemia depends on the numbers of microemboli, the diameters, and the typology of gas involved. In this context, we read the literature. We found a correlation with postoperative cognitive dysfunction, and delirium was associated with GME, with gaseous microemboli. And this is an interesting picture that explains that in our vessels, when we use cardiopulmonary bypass, this is a patient after mechanical ventilation that reported the post-operative cognitive dysfunction. The incidence of POCD is 50% after 60 months of the procedure. And the problem of the gaseous microemboli is in relation to the typologies of gas involved, such as nitrogen. And the composition of the gas microemboli, in particular for an expected predisposing factor in accidental decannulation, involve the nitrogen. We have different methods to assess the GME during the use of extracorporeal technology. The use of GAMP system to assess, to quantify the number of microemboli, the diameters and microliters and the volume, or the use of vascular probe, ultrasound probe. And this is a representation of the use of vascular probe in the venous reservoir during extracorporeal circulation for predisposing factors, the gaseous microembolic activity. And this is another movie on other reservoir without predisposing factor for gaseous microembolic activity in the intrath pump and in the vessels of the patients. In this context, we want to introduce this study that we conducted 2 years ago about the clinical evaluation of microembolic activity that we published on Membranes journal. In this paper, we collected 40 patients underwent cardiac surgery procedure for isolated aortic valve replacement, coronary arterial bypass graft, and minimal invasive mitral valve repair, and we use Horizon EF Plus. That is a device that improves the fluid dynamics of venous reservoir and improve the elimination of GME through arterial filter integrated in the oxygenator. We use the probe in the venous line and in the outlet of the venous reservoir in the arterial line through the gump use. This is the picture during the conduction of CPB in my center. And we found that the 45% of patients underwent cardiac surgery procedure with cardiopulmonary bypass reported unexpected factors predisposing the microembolic activity. 4 patients reported accidental air embolism from venous line for a time of 3 minutes. 10 patients reported low levels in venous reservoir in association with vacuum, more than 40 millimeters of mercury, and number 4 patients reported a combination of 2 excessive suction with low levels in venous reservoir in association with vacuum-assisted venous drainage. The 55% not reported unexpected predisposing factor. We conduct the analysis through the GAMT. We found that an association with increase of the number of microemboli for an expected predisposing factor we observe in particular for accidental air embolism from venous line. And the conclusion of this study is that the predisposing condition in terms of elimination of GME for this device is similar to the group of the patients that not reported predisposing factors in terms in particular of the total volume of the gaseous microemboli. We have 0.59 microliters versus 0.57 microliters. There is no statistically significant difference. And in terms of performance, the partial pressure of oxygen is really very good between the 2 groups in the patients that reported the predisposing factor of gaseous microemboli and not reported a problem in terms of thermal exchange. In conclusion, the patients that use the Horizon venous reservoir and oxygenator alone EF Plus with reported unexpected predisposing factor, not reported a statistical significant value in terms of GME volume in the arterial line. However, further study are needed to support this preliminary report. It's really difficult today correlated the gaseous microemboli with the postoperative cognitive disorders because are more multifactorial analysis. And the impact depends about the mean arterial pressure, the levels of anesthesia, the management of surgical field. And nevertheless, this disposable devices was effective in the elimination of GME for an unexpected predisposing factor. Thank you so much for your attention.
Thank you, Professor. After our third speaker, we should have about 10 minutes or so for questions, so line those up and we'll go right into it so that we can get ready for the 1:15 session that starts this afternoon. So our next speaker, very exciting, Professor Mirko Belliato, who has an MD and PhD from Pavia, Italy. He is the Director of Cardiothoracic Anesthesia and ICU for the Foundation San Matteo, Pavia, in Pavia. Research fields are the artificial lung, mechanical circulatory support, and mechanical ventilation systems. He's also been an ELSA member since 2016, and I believe you have the chair coming up, chair of Euro-ELSA, which is a phenomenal group up there, coming up in April. Well, this next month, huh? So good luck to you. 2 years, right? 2 years of pain and travel. Yes, okay. He's going to speak to us today on the innovative products that you saw at their booth or you saw in the videos, His title, ECMOLIFE and Colibri ECLS Solutions, 3 years of the Italian clinical experience. Do you have the drone here, by the way?
Thank you so much for the nice and kind introduction. Yes, I will be from the next month the president of Eurosets, so this is one of my first lecture as elected president. So I would like to go a step in the practical field. Nowadays, we have a lot of technical solution for pumping the blood during an ECMO support. And normally we thought that the levitating pump is the best in terms of sealing forces, pressure drops, heat generation, and so on. So why don't use this kind of technology in advanced device with the features that can be updated? We would like to have a device that can eliminate the particle or heat generation or reduce a lot this, reduce hemolysis, thrombus formation, no stagnation zone or very few stagnation zone inside the pump, so this means low risk of mechanical failure. One of the first concept to introduce is the shearing force during a use of volumetric centrifugal pump. This is a volumetric and color Doppler, similar to color Doppler evaluation of the velocity and the speed that is translated in stress and hemolysis. You can see from the center of the pump till the last point of the blade that the velocity change, the speed of the blood change, and indicate the vortex, the circus. That means that also the shaping and the number of the blades inside the pumps have some important significance. And these are two of the features that we asked several years ago to Eurosets. I was one of the chief advisor of the Eurosets. I asked them, why don't produce a pump with optimal flow dynamics, very low blood stagnation area? I would like to have a minimal friction, and shear stress, as mentioned before, with right number of blades, and that means low hemolysis. This is a computer rendering of the new pump that the R&D give us as a prototype in about 4 years ago. And you can see here seems to be a very small, quite small volume of inside volume of pump with a fully magnetic levitation system. And this is the rendering with the AutoCAD is a computer aid tool, and the testing in terms of number of blade. This is one of my question was, well, I would like to have the perfect number of blade, and seems to be that 6 blade have a lower pressure applied and lower speed of blood velocity, and reduce the shear and the stress forces applied to the blood that circulate inside the pumps. Second, I would like to understand if changing the number of the blade and the shape of the blade change the platelet activation, and seems that the median of 6 versus 12 blade is in favor of a 6 blade, lower platelet activation and lower stress accumulation by the platelet. That means less thrombogenous activation. And we moved from a lab to a patient, and this is a performance that we'd like to test before going on a patient. Was tested with a set flow at 5 liters per min for a time of 90 minutes, 3 liters per min for others 90 minutes, and go back to 5 and less at the end 6 liters per minute, always for 1.5 hours. And what's happened to the blood of our patient? The plasma-free hemoglobin still remain inside acceptable range. You can see here on the table that summarizes the result. And what about thrombus and fibrin deposit? You can see here that the center wall was clean, the top of the impeller was clean, the top of the pump was clean, the impeller was clean, just fibrin, no thrombus, but fibrin deposit in the pump tested, but very small fibrin deposit. Obviously, is not a miracle pump. It's always a real object with the physics that can be applied also. However, the fibrin deposit was very low respect the other kind of pump, and this is it's a strong point to start. 4 years ago, just a few months before the COVID season. The pump. This is one of the first patients in which we used the Euroset ECMOLIFE in the 2019 November, and the first patient and the second one was in 2020 during the COVID pandemic. We started, as you know, in the late February of 2020. After that, we have done a lot of patients and they have the opportunity to collect data. And collect also the free hemoglobin. You can see here, seems a very strange graph, because in 30 days of ECMO support, we collected the free hemoglobin, and there are 2 peaks inside. These 2 peaks are the dialysis. So during the ECMO course, there never happened an increasing of the free hemoglobin over than 20, that is similar to the 200 that I showed you before, just changing the unit of measures. And that means that in real life, the tested results are confirmed. The dialysis was the problem. And we go on this, but it's not, I don't have enough time to talk about the problems to connect the dialysis to the ECMO machine. But just keep in mind that if you have a hemolysis with a centrifugal levitating pump, probably is something else than is not the pumps. Also here, we kept a standard APTT value, also the ACT was kept in standard. And what's happened? Because this is a strange patient, because it's a patient that underwent ECMO for 3 months for COVID. And the ECMOLIFE was just the second pump that we used on this patient. And when we switch on the ECMOLIFE, the patient had 20,000 of dimer and very low platelet, lower than 50. We connect the patient to the ECMOLIFE, and the result was the dimer goes down. Obviously, the oxygenator, the circuit is new, but never goes up than 20, always remains inside an acceptable range for us, for our lab. But the platelet, increased. That means that inside the patient and inside the pump, inside the extracorporeal circuit, the wall extracorporeal circuit, reduce the phenomenon of activation of the platelet, as demonstrated in the study shown before. Also, the monitoring was very useful, especially during a very long trip of ECMO, because we have on the screen all the parameter measurement. Obviously, we use the ECMOLIFE for transport in different settings, and we were very facilitated by a very long life of the battery. The backup is inside the pumps, and this is a good choice for a cardiac ICU like mine, in which we have to treat patient, we have to bring patient, from heart failure, maybe biventricular failure, going to left ventricular failure, and waiting for transplantation of VAD long-term solution. And we use the ECMOLIFE for doing a temporary VAD, temporary ventricular access device. In such way, we put a cannula that was used for left ventricle unloading during the full VA support from the septal atrium to from the right atrium to the left atrium through the septal. And we put the cannula before for unload the left ventricle. After that, we remove the cannula of drainage, venous drainage, and we use this cannula such a drain of the arterial blood that comes from left atrium, and we re-inlet the blood in the iliac vein. It's like a VAD because the right ventricle is not assisted, just only the left ventricle is assisted. And you can go on for 1 month, for example, just to evaluate if you have to remove the oxygenator, obviously. You can evaluate if your patient is going on well. The second device that we tested since 2 years ago was the Colibri, because we have a program of ECPR out, in and out outside of hospital cardiac arrest. And we perform an ECPR on site, and we would like, and I asked to the company some ingredients for my machine, ideal machine. First of all, a wide range of application. I don't want to forget anything, so I would the gold standard features. And the Colibri, as mentioned before, was prepared for such kind of condition, moving from the outside to inside of the hospital with all the monitoring data available on the screen, plus a wireless tablet. All the data are collected and can be read on a tablet, on an iPad. It seems like an iPad with a wireless connection to the machine and with a wireless connection to the venous probe, arterial and venous probe for the blood, saturation, temperature, and so on. And why not to add ultrasound probes to make the cannulation under ultrasound guide during the ACPR procedure, and this was done thanks also to the battery. It is very long life, 200 minutes the battery inside the machine. So you can do a lot of kilometers, miles here in the USA with your transport backup machine inside your backpack. And what about moving the patient? They created like a fiber carbon plate to put behind the legs of the patient for moving from in such cases, the emergency department, where we put on a Colibri for cardiac arrest. Here is in an operating room, and we move to the cath lab. You can see here the Colibri behind between the legs of the patient with the foil that is particularly prepared also for the cath lab because it's in carbon fiber and cannot affect the diagnostic of the patient. As last, this is a first experience published on artificial organs a couple of months ago, in the last of 2023, and they found that all the parameters were good. I don't want to go inside the graph, but they are normal. Okay, that means the machine works normally, despite is very small, and all the stuff are wireless, and it's very simple to use. So the result, in a few words, is it's okay. This study just gives us the information that the machine done what you expect. And the summary, as a summary, all these points are important: magnetic levitation, advanced parameter. But I think that the smart transport solution for both, for residential ECMO pump as the ECMOLIFE, and the Colibri is poor transport pumps. And I don't mention, but it's important that you can combine both. When you arrive from your transport, you can connect directly the Colibri to the ECMOLIFE and create just a ECMO station done by ECMOLIFE plus the Colibri, and you can treat your patient, mix other things, and you can decide to switch totally to the ECMOLIFE and have the Colibri ready for another transport, or stay with this hybrid solution, because you have to move the patient to the CT scan and so on. So that means you save time for doing other stuff that is not checking the circuit, changing the circuits of the patient. And I think that's all. And I would like to say this is the name of innovation. So innovation in our field, it's really, really important, because we want to go on with the device, because the therapy and the patient are complex, more complex, and then go. Thank you so much. Time for
Fantastic. Can I have all the speakers' microphones on? We have about 10 minutes for questions. I'm going to start it off. For those that want to get up to a mic on either side, please do. The first question I have, and I think it's so cool, man, to have echo right there. You know, some of these patients that, you know, you're doing CPR on, they have no blood pressure. It's pretty hard to do a percutaneous cannulation if you can't feel a pulse. Have you yourself cannulated with echo in patients that have that are being rescued on a ECPR basis?
Yeah. Also, I cannulate patient with the ultrasound guided always. I think that the setting is really important. If you are in hospital, you can approach this kind of procedure very quickly. Outside the hospital, as we start now we are starting a study with the support of a Euroset for cannulation on site, as in your nation in Minnesota. Dimitri is doing, but with a very light machine as the Colibri ones, and just using the tablet for cannulation, respect all other stuff that like Dimitri have as the track with inside the angiography for cannulate the patient.
Is the resolution good enough that you're able to distinguish between artery and vein when you're going in to try to do a percutaneous cannulation with the Wi-Fi echo?
Yeah.
Wow.
Yeah.
It's pretty tough stuff. Thank you. The next question I had is, Carlo, maybe you can tell us that we're an international audience here, but maybe you can tell us what availability is of some of this innovative equipment at this point in time.
Yes, thanks for the question. So as I say at the beginning of my presentation, we are clearing the 510K, and today with the data that we have, we expect to be ready, let's say, beginning of next year. And we are trying to do everything is possible, maybe to speed up, but it seems a reliable data beginning of next year.
In the U.S., you're speaking in the U.S. Okay, so we're having issues like we do often of one company deciding not to produce some of the ECLS type equipment. They dropped that. I don't know if somebody's going to pick that up. We've had back orders on another company of free oxygenators, so we could sure use some innovation, some new equipment coming our way, and we applaud you to get it to us as soon as possible. Some exciting stuff coming up, and great work with your company. Appreciate it.
Yes.
Doctor, on your in vitro studies, when you were showing us, you said fibrin strands on the backside of the centrifugal pumps on the magnetic lev, and that's your own magnetic lev pumps, right? That's Eurosets? Okay, cool. Were you using anticoagulation on those? You were obviously using some kind of animal blood or human blood, but you were using some form of anticoagulation, but you still had the fibrin strand showing up on the backside of the cone. It laid flat, I noticed. Do you have any... No big deal, it's protein layering, or what do you think about that? Everything else was clean, I saw.
The study was conducted with whole blood, animal whole blood, and the was obvious. Sorry, it's a bad word, but very fresh, because we have to conserve the coagulation factor intact, and there was a layer at the bottom of the pump, but this is normal. I mean, we are in reality, in a really real world. So it's impossible don't have anything inside, but the importance is there is no activation of platelet. That means the thrombus is not formed. Just there is a fibrin deposit inside the line at the bottom of the pumps. This is a layer of fibrin. Obviously, probably we can, as I can say, improve the flow dynamics of the pumps. Obviously, yes. How to do it is I think is quite complex with the technology nowadays available in the science field. Probably we have to change totally the type of the pump going in a different and future that is not this technology. I mean, the same for the oxygenator. I'm doing a research with the 3D printed oxygenator membrane that mimic the lungs of the patients like a sponge, marine sponge, okay? This is a totally different technology. There's not a membrane inside a box of plastic, but is a really lungs 3D printed that the blood can go through and the air go through and ventilate like a real lungs. I think that it would be the same for the pumps. In the future, we will have a totally different technology, I suppose in 10 years.
I noticed in the design, the pumps are sitting horizontally rather than vertically. I doubt that has anything to do with it, but because it's horizontal, that's where the denser proteins could last. But I'm sure it's far more scientific than that, and flow characteristics. So that's the good stuff. Anybody else have a question for our speakers today? It was some excellent innovative products coming this way. One other thing, Professor Condello, you said 6% or 4 to 6% on air embolism on the venous side. Obviously not deleterious. That was just you measured air coming through the venous system, right?
Yes, correct. We reported 45% of patients reported unexpected predisposing factors for micro-embolic activity. 3 of this group of this percentage reported venous embolism from venous line here. The other reported low levels in venous reservoir with exceeding the vacuum. The other reported low levels, venous air in the venous line, and high vacuum excursion during this. Yeah.
Thank you.
You're welcome.
Your sales force in the country, what will it be? Do you know at this point, Carlo?
No, it's something that we have on plan for this year, for sure. The clear view that we have is when we will start in the right way. I mean, right way means with all the adequate people to support customers, because that is the most important thing.
Well,
step by step, to have the right organization for each area, each country, in order to support at the best, as we are doing in the rest, out of US, of course. So we will have all the right people to support our business, of course.
And all products will be made in Italy or different parts?
Yeah, exactly. Everything will be made in Italy, including oxygenator, etc. Everything.
The one thing we've seen over the years is a beautiful product come out, and all of a sudden there's a demand, and then you can't meet the demand. Of course, COVID and H1N1 hurt that a little bit. That was surprises to us, but just ramp up production when you can, and it's nice that it's domestically involved. You may have better control over that and know your expansion. So beautiful sales force and technicians, out there, clinicians to be able to call. All that stuff's so important to us in the field.
Correct.
Yeah. Anybody else have any questions before we? Well, thank you for a nice luncheon and a beautiful presentations for this summit, some innovative equipment coming to us. We take a break, and I think we start up at 1:15, if I'm right. Is that correct? Okay, so thank you all.